Good day to all of you. I'm Gideon Lasco, a medical anthropologist and a doctor, and I'm here to share with you some of my insights about doctor-patient communications. The first thing that I want to point out is that being a communicator is not really highlighted as one of the major roles of a doctor. We talk about leadership, we talk about research, we talk about clinician, we talk about the doctor being a teacher. But communications is not something that's highlighted in all of those, even though being a communicator is actually what all the roles envisioned for doctors have in common. We need to communicate whether we teach our students, whether we engage with our patients, whether we do research or take leadership roles in the community, do public health practice. All of these require communications. And it's vital for us. It's not just something that's nice to have, but communications is actually correlated with better health outcomes. It's good for both doctor and patient. This is quite obvious. But if you think about it, effective communications will allow you to achieve your goals, whether as a public health practitioner, whether as a researcher, a teacher, and of course, as a clinician. Now, the pandemic, which is still ongoing, has made communication even more important, especially in the doctor-patient interaction, because we have to rely more and more in communicating with patients in our practice, whether whichever specialty you have. So communications is all about building a relationship with your patients, exchanging information with the patients. So it's an information exchange. It's not just you trying to extract information from your patient, but it's also trying to inform the patient. It's trying to provide information to the patient. We'll be discussing that later. And communication is also vital to convey medical information and decision making to the patients. We need to arrive at decisions about therapy, about treatment options, and this requires communication. Now, of course, it's not just the patient that you need to communicate with, but also family members, significant others, other members of the therapeutic team. And that's also part of the objectives of communication. When we talk about barriers to good communication, the first thing that comes to my mind is social inequalities between doctors and patients. Belonging to a different social status is something that creates a lot of intangible and tangible gaps in communication. There's hesitancy from patients, shame and discomfort. There's a fear of being judged. The educational level, there can be words that are misunderstood. So the social inequality is really the foundation to many barriers to good communication. Cultural differences as well, independent of social inequalities, can affect the communication between doctors and patients. This can be more of a concern for multicultural countries like the US. But even in the Philippines, we also have some cultural differences within the country. And they can also contribute to impeding good communications. Time constraints as well, simply because there's no time to communicate. It impedes the interaction in itself. So we have to be mindful also of these pragmatic reasons to communication. There's simply not enough time to explain to patients what they need to know. And then technological barriers as well. Uh, even if we have used the same platform, even if we have the same Zoom platform or even Facebook video. But if the internet is not good, if the connection is not good, then that can serve as a technological barrier as well. So if you look at the diagram to the right, we can see how knowledge, health, beliefs, values, culture, and all of these power dynamics, we can actually move towards better communications. Now, this is not new in medicine. For decades, doctors have sought to explain these communications barriers, study them. There's a lot of research that's been done by doctors and even social scientists to explain and try to sort what are the barriers to communication. And if, as you can see, attitude really matters a lot as well, even more than the communication skills like nonverbal and verbal communication. So simply having an attitude of respect and empathy can already be a way to overcome communications problems. So I would say that to be a good communicator, you have to be a good doctor simply by embracing the values of medicine, which is empathy and respect, dignity. We can already be effective without realizing it. So good communications comes from the heart. Good communications comes from an effort to heal and a sincere attempt to empathize with the patients. That's the basic. But of course, we also need the skills to be a good communicator, and I will discuss some of them. First of all, listening, simply listening to the patient, actually inviting and devoting time for them to talk. It's already a big deal for them. And sometimes we don't realize it. Sometimes we don't realize that we're not listening enough to our patients. And at the heart of it, I think, is maybe our belief that we don't really need to learn anything from what the patient has to say. We already have a diagnosis. We already know what to do. Whether or not the patient talks doesn't matter. But for us, it won't doesn't matter. But for the patient, it does. So simply uh, committing to have some time to listen to the patient, regardless of the diagnostic value of what the patient has to say, is already an important step in the communications process. And it can be begin by allocating time, committing to really spending some significant time just listening to the patient instead of dismissing what they're going to say. Again, regardless of whether there's value, diagnostic value to what they're gonna say, not interrupting the patient while they're talking. So there are ways to channel the conversation in ways that are respectful and doesn't sound too abrupt. And I think you know what I'm talking about. Expressing interest through verbal and nonverbal cues. So it's very easy to see how if this is commonsensical. If someone you're talking to is interested with what you're saying or not. You can easily detect this. Any person can detect this. This is not just a medical skill, but it's a human skill. So people know, people detect, and studies show that patients listen. Patients are very attentive to the comportment of their doctors. So they will detect if you're interested or not. So express interest through verbal and nonverbal cues. Looking at your watch, for example, obviously you're already bored. So it will discourage the patient. So listening to the patient, again, is not just a matter of diagnostic value that, oh, I need to listen to the patient so I can come up with diagnosis. No, it's not just that. It's more than that. Listening to the patient is an end in itself. Listening to the patient is important in its own right because it allows the patient to share what's important for them. It allows the patient to to develop this kind of confidence that their stories matter. And I think that's at the heart of medical anthropology, which is the discipline that I try to bring into the medical field in general. But beyond your own attitudes and skills, there are also environmental considerations. So maybe the venue is not good. Maybe there are people watching, so the patient doesn't feel safe. So beyond your own individual skills and attitude, another way to facilitate this listening to the patient is to make sure that there's a venue where they can actually talk. Now, next to listening to the patient is speaking the patient's language. And this is something that can come in many forms. The first being the most important word in the patient's vocabulary, which is their name. Put value in the names of your patients. Call them by their name. Address them in ways that are respectful. It won't hurt to, between the word ate or miss, it won't hurt to use miss. And it can make people feel good about themselves. It feels dignified. It dignifies people to address them in respectful ways. Between kuya, sir, or manong, what do you think will make the patient feel better about themselves, feel valued and respected? So titles and addresses matter. Their names matter a lot. So put some effort in remembering and patients' names and addressing them by their names. To say I'm not good with names, it can sound arrogant because we never forget the names of the people that matter to us. So it can be a very powerful tool to actually address patients by their names. It can be very powerful. Now, another powerful way to make use of a patient's language is to allow them to define their own terms, to use their own terms and define them. We know that people use words like rayuma a lot, but it doesn't necessarily mean arthritis. People say pilay, but it doesn't necessarily mean fracture. Pilay is a very different word altogether. It means very different in folk medicine. So allow them to use their own definitions because it will also teach you something about how patients perceive healthcare. So don't impose your own categories and instead allow patients to define and use their own medical terminology. And this is very applicable in terms of symptoms and feelings. So sometimes on Twitter, I see images like the one that is on the right. So these are sometimes this is a joke for people to compare different adjectives. So tampo, picon, inis, and what are the levels? Uh, Look at letter D, kirot, sakit, hapdi. So what are how do you rank this? So of course, it can be a cause for levity, but at the same time, these words actually, the fact that these words are being compared actually makes sense because they are the words that people use and they don't use them arbitrarily. They don't use these words accidentally. They use it deliberately. These words have specific meanings. Ano ba yung ibig sabihin ng kirot? Anong kaibahan ng kirot sa sakit at hapdi? Because if people use the word hapdi or kirot, they might be saying something that we're missing out if we think that they're synonyms. They're not synonyms. They have slightly different meanings. So are we, especially for anesthesiologists who deal with pain a lot and different sensations related to feelings, are we sensitive to the different nuances of different words that we might end up dismissing as simply referring to pain? So let we need to be, and I need to learn from you as well because you know better than me in terms of this specificities of different words to talk about pain and manhid, di ba? We have different words for manhid, ngime, ngilay, ngalay, all of these words, we need to come up with the vocabulary. And sometimes we develop this vocabulary by experience. But for the purposes of not having to reinvent the wheel, we can pass on our clinical knowledge about these words. So that's our part of the research agenda that I will talk about later as well. But the point for this slide is we need to speak the patient's language. We need to mobilize the patient's vocabularies, starting with the most important word in their language, which is their name. So the third is, and quite related to the second, is practicing cultural sensitivity. Oftentimes we dismiss the words that patients use for their illness because it doesn't exist in our textbooks. But it doesn't make that non-existence, it doesn't make it any less real for them. For example, when patients talk about usog, when patients talk about pasma or kulang, what exactly do they mean? So we need to be aware of these folk illnesses. We need to be aware of how they try to explain these illnesses. We don't have to believe in them. So medical anthropology is not about trying to believe in what patients say per se, but it's about respecting what they believe in, acknowledging the value of their narratives, whether or not we can find clinical basis or not. And also acknowledging patients' positionality. So there might be gender differences in talking about pain. This has been studied as well a lot in the literature. Males tend to be less forthcoming about their experience of pain, for example. Uh, Age can also matter. If you're dealing with a teenager, there might be special need. They might be more hesitant to talk about certain issues. So obviously, obviously, this is something that we know by experience, but at the same time, sometimes we forget about this. So acknowledging patients' positionalities, whether it's gender, age, even ethnicity, all of these matter, and accounting for their needs. There might be special needs for certain demographics. For example, Muslims during Ramadan, can they can they take this kind of medication, or are you sensitive enough to recognize that they are actually fasting during a certain time of the year? And of course, you will have to plan your therapy accordingly. So there are many issues involved in cultural sensitivity. It can also be the way you address them. So an elder, an elder who's used to being respected, a respected part of the community, of course that person will be offended if you just talk up to him without acknowledging his position in the community. So practicing cultural sensitivity matters a lot. Now, more pragmatically and more technically speaking, we need to mobilize also the nonverbal aspect of communication. So beyond the content of what we say and what we listen to, we can mobilize the the tone of voice in itself as a way of conveying empathy and warmth. So this is something that, again, like I said earlier, at the heart of communications is empathy, the desire to heal, the desire to help is at the heart of good communication. So this will be reflected in our tone of voice. Making eye contact also matters. It can depend on the context. So this might not be applicable in all situations, but in many instances, and if you look at this study, although I think it was done in Singapore and other settings, people mentioned about eye contact, facial expression some of the criticisms they made for their doctors. So this is also important. These nonverbal cues, facial expressions, again, avoiding gestures like looking at your watch, dressing appropriately. Because in some settings, people expect doctors to wear white. In other settings, they feel that a less formal, a less uniform way of dressing is more makes them more approachable, and therefore it facilitates communications. And appropriately using tactile gestures like shaking hands, it makes people feel important if you shake their hands as if it were a business transaction in some settings. Of course, now with COVID, this is not something that is possible. I'm sure many of you have seen this viral photo of how the Brazilian medics tried to replicate the tactile, the importance of the sense of touch with this hand of God that they put up for critically ill COVID patients. But tactile gestures matter. So when we do get back to the old way of dealing with people, I hope that we don't lose sight. I hope we don't lose touch of the importance of tactile gestures. Now, fifth is tapping the power of symbols. The stethoscope is particularly powerful because it's both a symbol and substance of listening. Oftentimes, patients expect doctors to use their stethoscopes to them because they ascribe importance to the stethoscope. For them, the stethoscope is a sign that the doctor has listened to them, listened to their bodies. But it symbolizes listening, which is why it's very important. But many doctors don't use it because they don't think it's needed. But again, good communications accounts for not just what doctors need, but what the patients expect and what the patients will appreciate. So I would recommend really using the stethoscope because it's a symbol of healing, it's a symbol of listening. And there are other symbols as well, but I want to highlight the stethoscope because it's highly symbolic. It's a powerful symbol of medicine. And if you auscultate a patient, you show that you've listened to their bodies and they will appreciate it, I tell you. Now, finally, because we're now in the age of online consultations, telemedicine, we need to embrace online communications. Many of us have been hesitant to go to social media, create all kinds of online presences, but at the same time, I think that if we are to reach our public, if we are to bridge the gap between doctors and patients, we have to embrace online communications. So this includes social media, where simply being there can establish your credibility and equanimity, amiability. So it can build rapport even before you encounter patients with limits, of course. We have to set boundaries as well, which can be very difficult to set in this time. But social media can definitely play a role. Now, telemedicine requires even more of the facial expressions and verbal communications that I mentioned earlier. This can be a skill in itself because, in my experience in teaching students in Zoom, I found myself having to practice tonality, like changing my vocal repertoire from time to time because there are, you cannot use gestures a lot in in Zoom. Although we are encouraged to by some scholars to use hand gestures because they make the space more interactive. That even though the screen is 2D, it can make things look more complex and more vivid. And I also believe in that. But at the same time, telemedicine has risks in themselves. They can offer less room for context. They can they can be a source of misunderstanding because you don't really see what's going on. Is the patient uh, baka may niluluto, di ba? And worried about baka nasusunog na yung kanin. So, it's very different. It can be very different. But at the same time, there might be some topics where people can feel more comfortable because it can they can be able to share their problems in private with parang Zoom. Maybe a teenager can open up more because he's in his room. So there are many nuances in online communication. This is an ongoing learning experience for all of us. And we will need to study more how online communication can be mobilized for patient care. Now, and it brings me to the institutional level. We need to incorporate communication skills in the curricula. This is not just something that we can leave for experience for students, residents to learn on their own. We can actually codify our collective experiences and incorporate them in curricula. There are specialty specific communications needs. So I would imagine that for anesthesia care, issues about pain management, issues about disclosure, informed consent with the operating room, with anesthesia, etc., will be at the forefront of your communications concerns. So we need to have this specialty specific communications needs be part of the research agenda for communications research. And we can work together. Social scientists, specialists can work together to do research on how best to communicate with our patients. Now, in summary, these are some of the things we can immediately apply to the patient interaction. Something that we can also apply to other settings like the public and our colleagues. But it entails, first of all, listening to the patient, speaking their language, practicing cultural sensitivity, mobilizing nonverbal communication, tapping the power of symbols, especially the stethoscope, and embracing online engagement as we try to continue quality healthcare during the pandemic and beyond. So thank you everyone, and I look forward to the open forum.